Hello, everybody. I am happy to be here. Thank you for the opportunity to be here. And I will present our perspectives on non-invasive PGT-A and what we... Yes, like this? Yeah. Well, I think I speak loud enough. Okay, thank you. So I come from Romania. I represent here Gynatal. It's in western part of Romania, in Timișoara. I will skip the lab because I'm a clinician, and I will present the clinician perspective on this theme. So our recommendation for non-invasive PGT-A, first of all, like everybody said, is advanced maternal age. Then severe oligospermia, recurrent implantation failure, recurrent miscarriages, known chromosomal alteration in parents' karyotype, and, of course, couple desire. I'm not sure how things work in your country, but in Romania we have a lot Google-informed patients who come to our clinic with, I don't know, very inflexible desire to do IVF with PGT-A. So we can't say no. This is how things work. So this is one of the recommendations. Why non-invasive? Well, first because our embryologist and us, of course, think it's with less biopsy trauma. Well, because studies have shown a high concordance between non-invasive and biopsy PGT-A. It gives comfort, psychological comfort for the patient, and that leads to a better compliance from the patients. And we also do biopsy PGT-A, but it is reserved to selected couples. Well, how things work? We have a team. It is formed by the gynecologist, the embryologist, and the genetician. When the couple first comes to the clinic, of course, the first discussion is with the gynecologist. The gynecologist makes the recommendation for non-invasive PGT-A. Then the couple has another discussion with the embryologist. It reconfirms the recommendation, explains advantages and the disadvantages, and also the most important part, performs the PGT-A. Then, when the results come, this is something that we discuss also with the genetician. If the embryos are euploid, then it is easy. We transfer because we prioritize, of course, euploid embryos. But sometimes we don't have euploid embryos, or sometimes we transfer euploid embryos who don't turn in a pregnancy. Then there is a discussion. What do we do? So sometimes we transfer aneuploid or inconclusive embryos. In Romania, it is not legal to discard embryos just because they are aneuploid. So we need a written consent from the couple if we want to do that. In the situation when we transfer aneuploid or inconclusive embryos, we address the couple to the maternal-fetal unit to do all the genetical screening tests in the first trimester of pregnancy. So this is our results. We had 86 patients for non-invasive PGT-A. I'm not sure if this is a large or a small number, but these are our patients. We tested 245 embryos. We don't test all the obtained embryos. This is not the number of the obtained embryos, it's just the number of the tested embryos. We obtained 78 euploid embryos, that means about 32%. 45 patients had euploid embryos, and from these 45, just 42 transferred. So our pregnancy rate is about 64, But what is important is that we also transferred 11 aneuploid or inconclusive embryos, and we obtained 6 pregnancies. That is a very high number. 45% of the inconclusive or aneuploid embryos turned into pregnancy. Our amplification failure rate was around 7, so I think it's in the average. Well, I split the patients in 3 groups, under 35, between 36-41, and above 42. And in the first group, we had 25 patients with 97 embryos tested. This is the group who had, obviously, more embryos. And we tested only 97 because some patients had more embryos, like 6, for example, and they didn't have enough money to test all the embryos. From these 97, we had 38 euploids, 37 with 37 patients, actually, and 12 pregnancies obtained, which is very interesting, let's say, is that we transferred to inconclusive embryos, and we had 1 pregnancy, and we transferred to aneuploid, from which one was chaotic, and we had 1 pregnancy. And that chaotic embryo actually turned into a very healthy baby boy, who is now 7 or 8 months old. Second group, 37 patients with 92 embryos tested and 32 euploid embryos. From this group, 20 patients with euploid embryos, 13 pregnancies obtained, a lower rate, but I think it's concordance with the age. 1 inconclusive embryo transferred, 1 pregnancy, and 4 aneuploid embryos, 2 pregnancies. The last group, 24 patients above 42 years old. We had 58 embryos, but only 8 were euploid. Well, it was one patient, each patient had 1 euploid embryos because there were 8 females, 8 euploid embryos. We transferred from these only 5, 3 didn't transfer yet. We transferred 5 euploid embryos. We obtained 3 pregnancies, let's say 3 positive pregnancy tests, not 3 pregnancies, because just 1 is ongoing pregnancy. And we had 1 inconclusive embryo, no pregnancy, and 3 aneuploid embryos, 1 pregnancy. I think that in the above 42 years old group, we should think more about these women, because if we compare with the ovodonation program, we have more female above 42 who get pregnant with ovodonation than with their own euploid embryos, and this should be a discussion. So age is not just a number, although we want to be, and we want to relate to age just a usual number, but it's not, because in the under 35 years old group, we had more embryos, more higher euploid rate, and of course a higher pregnancy rate, compared to the above 42 years old, where we had obviously less embryo, a lower euploid rate, and of course a lower pregnancy rate. So my conclusions are that non-invasive PGT-A is a very useful tool to prioritize embryos to transfer. Our clinical results reconfirm what we already know, that the younger women are, the more embryos, more euploid embryos, and more pregnancies obtained. It's wider perspective if we work as a team along with the genetician. And obviously, yes, we need more studies, but for me, non-invasive PGT-A along with artificial intelligence are the future in the IV lab. Thank you.